Hello, good morning everyone. Welcome to our web show, It's All in Your Head. Today we will be talking about the treatment of the emotional trauma. Dr. Paul Swingle is here with me today, and I'd like to give you a little introduction of Dr. Swingle before I pass it on. Dr. Swingle was titular full professor of psychology at the University of Ottawa prior to moving to Vancouver. Fellow of the Canadian Psychological Association, Dr. Swingle was lecturer in psychiatry at Harvard Medical School, attending psychologist at McLean's Hospital in Boston, where he also was coordinator of the Clinical Psychophysiology Service. Dr. Swingle is registered psychologist in British Columbia, certified in biofeedback and neurotherapy. His newest book, Biofeedback for the Brain, was published by Rutgers University Press, and the book is available at soundhealthproducts.com. We will have 2 intermissions during this webcast, so we can answer any questions that you might have. To send us your questions, please use the chat feature on the control panel on your right. And we are all set here, so let's get the show started. Good morning, Dr. Swingle.
Good morning. And good morning, folks. Today we're going to be talking about a very, very interesting area, and that is emotional trauma. This is a situation in which if you treat it correctly, then the person's life can get on as usual. If you mess it up, then the person can have a lifelong problem. So it's a very serious issue, and we're going to be talking about a lot of the different aspects of this. There are a lot of terms that are used for the treatment of traumatic experience. So we have labels like post-traumatic stress disorder, acute stress disorder, pseudo-seizure disorder, and so forth and so on. What we'll be doing today is having a look at how, if you look at brain architecture, that is the brainwave profile in the person, you can tell an enormous amount about how the trauma has affected the brain functioning, and secondarily what kind of predispositions the person may have had that are triggered by the trauma. Now, there are properties associated with the event itself that are critical. For example, some traumas are associated with a unique event, such as a home invasion, for example. Others have go over a long period of time, something like bullying, for example. And the characteristics associated with those kinds of experiences differ. You also have the issue of predisposition. That is, what is your genotype? That is, what's your genetic makeup? Are you predisposed to depression, for example? Are you predisposed to a sleep disturbance? Are you predisposed to anxiety, and so forth? The trauma and the traumatic event could trigger the manifestation of something like a severe predisposition to depression. Now, we're going to be going over all of these things today, or at least as far as we can get. The effects of trauma, it can affect, obviously, your emotional life, but it can affect your health in a very serious way, and cognitive processing. The treatment that we're going to be talking about, neurological treatment, what we do, we're going to be talking about some of the problems associated with trying to blunt or sedate this condition, which never works, and the issues associated with how you process and deal with the significance of the traumatic event. Okay. Now, the risk factors for developing post-traumatic stress disorder. Now, this is the most serious condition associated with exposure to severe emotional stress. And the average after a trauma is about 8% for men, about 20% for females. Childhood trauma, chronic adversity, family stresses are all factors that play into the risk factor. So if you have a history of traumatic events in your childhood, then the probability that a serious traumatic event is going to trigger post-traumatic stress disorder is enhanced. Family stressors, living in poverty, things of that nature are all associated with this. Now, this is an interesting issue, parental trauma. Now, there's an increased risk for individuals to develop post-traumatic stress disorder if their parent has been exposed, if the mother has been exposed to a severe trauma, in particular during gestation. Now, this is very interesting data that came from Holocaust survivors. The children, offspring of female Holocaust survivors, have lower cortisol levels. Now, cortisol, as we will be seeing, is associated with stress tolerance. And there's some very interesting data associated with that, and some of the things we're doing in the clinic in terms of understanding how we can modulate cortisol levels. Sleep, for example, is the critical element here. 30% of the variance in post-traumatic stress disorder is genetic, and we'll be going over a lot about that shortly. And as I was just saying, cortisol is important in restoring homeostasis after a stress response. Trauma survivors with low cortisol experience longer and more distressing response. So cortisol is important here. Post-traumatic stress disorder is associated with disruption of the hypothalamic pituitary adrenal axis. Basically, it's associated with, again, cortisol. And low cortisol is one of the distinctive features in the profile that differentiates those who respond to an emotional event with post-traumatic stress disorder versus other conditions. And blunted alpha, which is what we see when we're doing our brain maps, and it's a neurological response, and it identifies individuals who have not dealt with trauma efficiently, and the brain registers that. The brain tells us everything, as you will soon see. Now, cortisol is extremely important, and this is just the monitoring of cortisol over a full day period, 24 hours. Now, the interesting thing here, now this is not a person with post-traumatic stress disorder. I'm just demonstrating here what the effect of efficient sleep is. So here's the cortisol level at noon. Here it is at when the person gets home from work. So this person is really spent by the time they're getting home. They're, if you want to think of it this way, using up all their cortisol for dealing with the stresses of the day. Mild recovery when the person's relaxing at home, but look at the efficiency of this sleep. And the cortisol level is huge when the person wakes up. So you can see what it is. It's just like a hydraulic system. The sleep restores it, it's used during the day. Sleep restores it, it's used during the day. Nice efficient system. Everybody knows that there can be severe health risks associated with stress. That's particularly true with traumatic stress, and it's doubly true if the traumatic stress is not dealt with efficiently. So, and if we just look at the odds ratios here, this is for gastrointestinal disorders. It's at least 1.5 to 2 times what the general population. Cardiovascular disease, arthritis, hepatic diseases, stroke, diabetes. In general, over the post-traumatic stress disorder increases risk in general of some sort of physical health condition in the elderly population. Post-traumatic stress disorder triggers other things, and that's exactly what we'll be talking about here. What does the person walk into the situation with? So, as you can see here from these data, from the DSM-5, 80% or more are likely to have at least one other mental condition, like depression, for example. Substance abuse and conduct disorders are huge effects of post-traumatic stress disorder. Now, the interesting thing is combat veterans. This comes as no surprise, but later we'll see that we have to look at the symptoms associated with traumatic brain injury when we're talking about individuals who sustain the traumatic event in some sort of condition that might give rise to a head injury, like an automobile accident, and certainly combat veterans. In children, one of the prominent manifestations of a traumatic event is oppositional defiant disorder and social anxiety, separation anxiety. The twin studies, these tell us a huge amount. If you have military veteran male twins and one of them develops post-traumatic stress disorder, what's the probability that the other one will? And what we find is that the odds ratios with a lot of these kinds of conditions anywhere from 20 to 30%. Now, this is the study I really like to show. And this is the genetic predisposition associated with schizophrenia. Now, schizophrenia has a heritable load. That is, part of it is your genes and inherited. And if you take monozygotic, that is identical twins, and one of them has schizophrenia, what's the probability that the second one will? Well, it's, let's say 50%. But the interesting statistic is 50% will not. So we're always looking at triggers here. You can have a predisposition for all sorts of things, but something has to turn the key. And trauma is a major key lock turner for this sort of thing. Potentially traumatic experiences. What that means is if you experience a very severe emotional event, what's the probability that that's going to evolve into post-traumatic stress disorder? Now, where that really came home to me was when I was at Harvard Medical School in McLean Hospital. I used to treat a lot of combat veterans, Vietnam veterans. And there was one fellow who was hospitalized because of post-traumatic stress disorder. And he would be visited by his buddies. And I used to sit around and schmooze with these guys. And what was interesting to me is you would have 3 or 4 guys who all experienced exactly the same event. Why is one guy disabled by it? The other, vets might have had sleep disturbances, might have had to have a bit of counseling, or don't want to talk about it. That's very common. But they're not disabled by it. What's the difference? Now, this is looking at adolescents with potentially traumatic experiences. The interesting data here from my perspective is just how much of this our teens are exposed to. 61% of teens exposed to at least one potentially traumatic experience in their life. Now, these are teenagers now, up to 17 years of age. And that includes violence such as rape, physical abuse, witnessing domestic violence, as well as injuries, natural disasters, and so forth. Now, the number of these kids that develop post-traumatic stress disorder within the measurement period was about 4.5%, which is the rate that's very close to that of adults. And again, the usual distribution of more females than males. Now, the other thing about this, by the way, is if a child has been exposed to a severe traumatic experience and doesn't manifest any major symptoms, one of the things we have now discovered is that the effects of traumatic stress, particularly a significant traumatic event, can evolve and manifest years after the actual event. So there seems to be an incubation effect, or other experiences trigger and combine with the traumatic event, so that it manifests as some sort of symptoms. Now, what we're looking at here is a nicely functioning brain. And what we have is we have electrodes on the head, and we are measuring the electroencephalograph. That's what you're looking at here, the EEG. On the top, we have the raw signal. That's the electrical signal that's coming out of a particular site on the brain. Now, we can break that signal down into its components using what's called fast Fourier analysis. It's a statistical procedure for picking out different waveforms. So within this raw signal, we have theta, which is the blue line. Theta are slow brain waves between 3 and 7 cycles a second. And it's associated with all kinds of things depending upon where in the brain we find it. In some areas we want to see a lot of it because it's a quieting, has a quieting effect on the brain. In other areas we don't want to see a lot of it, like up in the front part of the brain, which is supposed to be doing all our work for us. It's the executive portion of the brain. We don't want to see a lot of slow frequency up there. Alpha, the purple one here, 8 to 12 cycles a second. Alpha is extremely important waveform. That's the one we're going to be talking about in just a minute now. And then beta is the fast frequency, 16 to 25 cycles a second. That's when the brain's lit up. Now, what we're looking at on the bottom here is called the spectral display. And all of these are brain waves in 1 cycle a second bins. And it goes from very slow, 0.5, that is a half a cycle a second, down to 40 cycles a second. Okay, and it should look like this. That is, the higher the frequency, the lower the amplitude. So the algorithm is frequency is inversely related to amplitude or strength. Okay. Now, this is what's called an alpha response. We have the electrodes sitting on top of the head, and here's our distribution again. And this is when the person has their eyes open, and then they're going to close their eyes. And right around here where I have my cursor, you're going to see that area jump, and that alpha is going to get very strong. Here it is. See? And that's when the person closes their eyes. We get a nice jump in alpha. And then when they open their eyes, it will drop like a stone. There you go. Okay, so that's an alpha response. What about a person who has been traumatized? This is what it looks like. First of all, you can see that we don't have that nice distribution. Okay, it doesn't look quite as healthy as the last one. And if you watch this area here again, when the eyes are closed, you'll see it'll bounce up every once in a while, but it won't stay there. And it's what we call a blunted alpha response. And that is a marker for trauma. See, it comes up, it can't stay there. So there's your trauma marker. Now what this is the brain is putting out a lot of energy to try to prevent you from feeling the emotional pain associated with the trauma. And here's where you'll find that blunting. Here's the nose up here, and right on top of the head, and in the occipital region in the brain, you're not going to get an alpha response. That is, when you close your eyes, it's not going to come up the way it should. That is, it doesn't strengthen. And here's what it looks like on a raw data summary. This is the alpha response right on top of the head, and this is the alpha response in the back. So this person has depression but no trauma. And this is depression with trauma. You can see when that person closed her eyes, it actually got weaker, not stronger, and the same is true in the back of the brain. So we can see instantly, in terms of the numbers here, when an individual has been exposed to a severe emotional stressor, and more importantly, it hasn't been adequately dealt with or processed, as we say. So depression triggered by trauma would look something like this. There's too much fast activity over on the right side of the brain, and we have the deficient alpha. This is what trauma with depression would look like, or at least one form of it. And we can see this instantly when we do our assessments.
Thank you, Dr. Swingle. This is our first Q&A break, and to all the listeners, if you do have questions, again, you can send them through the chat feature. Just type your questions in the chat box located on the control panel and send them over. First question, doesn't everybody have emotional trauma at some point in their lives?
Yeah, sure. We all have trials and tribulations, and if you want to call it trauma. Trauma is probably not a good word to use for this. We need something else. Trauma always suggests sensational, and it could be, low level but cumulative. The question, of course, is, are we prepared to deal with it? What is our emotional makeup? How robust are we? And we can tell a lot of that by having a look at the brain assessments. And of course, the people we see in the clinic are the people who have not dealt with emotional trauma efficiently because of neurological reasons. Now, this brings up another interesting issue. What we're doing with like police agencies is we are having a look before the cadets go out actually into the field, into the policing arenas, as we say, and we have a look at the brain and make sure they are stress tolerant.
I have recently met several people who say their doctor has told them they have post-traumatic stress disorder. Why are we seeing more of this?
It's interesting. We kind of have medications of the week, flavors of the week, and we have disorders of the week too. I agree with you. We seem to be seeing an awful lot of folks who somebody has told them they have post-traumatic stress disorder, and it doesn't even come close in my estimation. Post-traumatic stress disorder is a severely disabling condition. You have detachments in which you're suddenly back in the event and you're absolutely unaware of your surroundings. That's very different than somebody who is just having some bad memories about what happened previously. So I agree with you. I think there's an overuse of this terminology.
Are there any medications that are effective for post-traumatic stress disorder?
We'll be going over that in detail in just a few minutes. Generally speaking, you do not want to sedate an emotional trauma, but we'll talk about that more fully in just a few moments.
Thank you, Dr. Swingle. We'll move on now.
Okay. Now, we were talking about trauma-based depression, and here's a situation in which, again, if you look at these markers here, we can see that we're not getting a nice strong alpha response, but we don't have any markers anywhere in the brain for depression. So I'll be showing you more detail about this. We can look in the brain and see whether an individual has a predisposition to depression or is experiencing what we call a reactive depression. For example, if somebody dies, you're supposed to feel sad, and the brain shows us that. Which you don't want to suppress, by the way. You're supposed to feel sad and deal with it. Now, here's a situation in which this person has no depression markers at all, only has trauma markers. So this individual is likely to be treated for depression with an antidepressant, which is absolutely ineffective against this kind of condition because this is trauma, not depression. Now the person feels depressed because they feel that they can't cope. Now, we're talking about trauma-precipitated depression. That's very different than somebody calling trauma, that is, the bad feelings they have about trauma, depression. Now, this is trauma-triggered depression. That is, the individual had a genetic marker for predisposition to depression, and this is what turned the key. So I know, see that circled area, and that should be 30% greater than that 9.1. It's only about 10%. So I know there's a trauma marker here. And then I see in the front part of the brain that this individual has a genetic marker for predisposition to depression. And that's the difference here in beta, in which beta on the right is about 35% excuse me, greater than it is on the left. The person was happy as a clam until they experienced the trauma. Once the trauma hit, then this person spent a number of years in severe depression, and what it was a trauma-precipitated depression. That is, the trauma turned the key on that predisposition. And we get this in a variety of different circumstances. Here's another one in which this is the actual raw data. So there's the eyes closed. Now remember, that should be about 30% greater than that 8.7. That's what we're measuring in terms of an alpha response. You see it went negative. And the individual has that disparity between the right and the left in the front part of the brain. F4 is the right part of the brain. F3 is the left front part of the brain. Here it is here. So this is a trauma-precipitated endogenous depression. Now, this is a trauma-precipitated reactive depression. Now, this is interesting because a good example of this is bullying. This person has the trauma markers here, and they have what we call reactive depression. And reactive depression is a little different configuration in the front part of the brain, and that is where you get excessive slow frequency in the left side of the brain, and that's shown over here. So as soon as I see this, I want to know what's going on. Okay, the person came in for depression or anxiety, but the brain tells me absolutely everything about what I need to know here. Here's another one, and this is also, there's your trauma, and in this case we have elevated alpha on the left relative to the right, and that also is a marker for reactive depression. Now, there's been a lot of research done on this. What if we just make somebody sad by showing them sad pictures, or having them read sad stories, or have them watch a film clip of a very sad event? Well, what happens is you get that elevated alpha over on the left side of the brain, in terms of the brain is showing me that you're unhappy. Okay, so that's a reactive depression. Now, when I see this, I want to know about bullying, family problems, and so forth and so on. Okay, so what does all this look like? And these are the areas that we've been talking about in which there's deficient alpha response. You're not getting enough alpha coming out of that area of the brain when you close your eyes. So I know that the person's been exposed to a severe emotional stressor. Second thing, what about stress tolerance? If there's too much fast activity in the back of the brain, then I know that person is not stress tolerant. So the effect of this trauma is going to be more severe in this person because they have a predisposition, a genetic predisposition to poor stress tolerance. It may affect their sleep too, which we'll talk about in just a minute. And if it's a reactive depression, then there's too much alpha or theta slow frequency over on this side. Now slow frequency, if you remember from our initial discussion, when there's slow frequency, what that means is the brain is slowing down. So it's suppressing the activity. Or if it's an endogenous, that is a genetic predisposition, then it's too much beta on this side. And the equation or the format for determining depression is when the right side of the brain is much more active than the left. That's your marker for depression. If the depression is because of too much slow frequency on the left, meaning that the brain is shutting itself down, that's a reactive depression usually. If it's too much beta, fast frequency over on the right, then that's a genetic marker. So too much slow frequency over here. I'm sorry, too much fast frequency over here. That's your marker for genetic depression. Too much slow frequency over here. That's your marker for reactive depression. Not enough alpha here when you close your eyes. Not enough alpha here when you close your eyes. That's your marker for exposure to trauma. And if in the back of the brain you have too much fast activity relative to the slow, then that's poor stress tolerance. And we can tell all of that by looking at your electroencephalogram. Okay, so an actual client. This is a person with trauma. You see it there. Depression. Okay, you see it right there. That is too much beta, or imbalance in beta in the front part of the brain, with more beta on the right relative to the left, and very poor stress tolerance. Now we haven't talked about this area yet other than my pointing it out on the schematic. What we want to see here is we want to see a nice relationship between slow frequency and fast. We want those numbers up or closer to 2. That is the ratio of slow to fast activity amplitudes. And this person has poor stress tolerance, problem with sleep, trauma marker, and a depression marker. Now, one of the symptoms associated, one of the patterns or syndromes associated with post-traumatic stress disorder is what used to be called pseudo-seizure disorder. Now, what's a pseudo-seizure? And what we're looking at here is the electrical conductivity of the skin. A lot of you folks may remember we used to call this the galvanic skin response. That is, if we put electrodes on your fingers and measure the resistance, that is how much sweat is coming out of the finger, so to speak. If I startle you by clapping my hands behind your head, you're going to have a big jump in that response, just like we're showing here. Now, one of the things that we found with pseudo-seizure disorder is if the person becomes more aroused physiologically, then you're very likely to trigger a seizure. But it's not an epileptic seizure. You don't see anything on the EEG that's at all indicative of any kind of seizure disorder. Okay. Now, what it turns out is that pseudo-seizure is very often the body's response to blocking the pain and the emotional suffering associated with some some trauma history. And in that case, what we're dealing with here is that the seizure is defensive. Now, the seizure doesn't have to be like this person who had full myoclonic seizures. It looked exactly like epilepsy. It can be fainting, it can be falling asleep, things of that nature. Now, the other thing that we often find with trauma is what we call hypervigilance. If you've been traumatized, very often what happens is you just can't let the front part of your brain relax. You're always looking, that notion that you're always looking over your shoulder. Well, that's what this looks like. And what we have here is a deficiency of alpha in the front part of the brain. In other words, the brain is not efficient at parking itself when it's not actually being utilized for some particular reason. And what that looks like is there are trauma areas that is deficient alpha and then low alpha in the front. So here's a hypervigilance profile. We know there's trauma, but we know that this person just can't let their guard down, always looking over their shoulders, so to speak. We get an awful lot of kids coming in here with diagnosis of ADD and excuse me, all kinds of learning kind of issues. And when we look at the brain assessment, which is what you're looking at here, it looks like we've got an issue here other than any learning or ADD or inattentiveness. Now, what we're seeing here is I'm looking at the markers associated with one form of ADD. And there's a very mild marker for that, the ADD. But the big issue here is this kid has a trauma marker. See, right there. Right on top of the head, we're not getting adequate alpha response. So I have a flag that goes up immediately. Okay, what's going on here? True, mild attention form of ADD, but that's not what's causing the trouble here. Back of the brain, child is having some sleep problems. Front part of the brain, huge marker for reactive depression. Okay, so we've got a trauma marker and we have a marker for major reactive depression. Something's going on with this kid. So digging around, I'm going to dig around about family situations, so forth and so on, but it turns out that this child was being severely bullied. Didn't let his parents know because the bully had threatened him, which is common. Now, I know a little more about this kid. We don't have enough time to go into it, but he has a marker for major emotional reactivity, emotional volatility. So this is the kind of kid that reacts, and he's very likely to start crying with very minimal provocation. So he's a sitting duck for a bully. Now, it's the brain assessment that told me all of this. This kid was brought in to treat ADD, and we could treat ADD and it might help a bit, but this kid can't study because he's frightened. Can't pay attention at school because he's frightened. He's hyper-reactive. So, as I said, he's a sitting duck for bullies. And the news about bullied kids is not good. We have this notion, at least when I grew up, everybody gets bullied, you get over it, and you have to learn to stand up for yourself, all that sort of business. But if we look at the long-term effects of some of this, it's not trivial. So if you're looking just at the odds for a psychotic symptom, and it's about twice the average range for individuals that have histories of bullying. And if it's repeated bullying, it goes up very substantially. It jumps to about 4.5 times what it is for the general population. And if we look at the adult sequel of childhood bullying, it's not pleasant either. These are the odds ratios of individuals who have been victims of bullies or have been both bullies themselves and victims. And you can see that agoraphobia, fear of going outside, fear of open spaces, pretty large. 5 times the actual, the general population risk rate. if you've been both bully and victim, it's very interesting. These numbers get much, much, much larger. So depression alone is about 5 times more likely than the general population. Panic disorder, suicidality.
Thank you, Dr. Swingle, and we have a few more questions here. What kind of success was achievable there with the bullied boy?
100%. Once we got that all sorted out, the parents went down to the school took care of that. What we did with the child is help them redefine the bullying event, which is one of the processing procedures. And then secondarily, we took care of the imbalances in the front part of the brain, so we made them far less emotionally volatile. And it only took a couple of sessions to take care of that mild ADD marker. That was not a big deal. That's not why that child was sitting in front of me.
Can PTSD actually be cured?
Yes. It depends on many, many, many variables. What was the event? How was it initially treated? How long post-event? Excuse me.
My father was a World War II veteran, and he says that they had secret medication for this problem called booze. I know he was joking, but it does seem like many more vets are diagnosed with PTSD now than before. Is this because we pay more attention to it?
Probably. Way back when, it was considered shell shock. They didn't even have the term PTSD. And also there was a humiliation associated with individual not being able to function after coming back from the battle theaters. There was also, Vet was talking to me one time about, it's interesting, the fellow said booze, but there was one battle theater they were in which they rotated the troops out and then they gave them liberty in some city or town or whatever it was, and they all got rip-roaring drunk for 3 or 4 days and then went back into the battle theater. And the guy felt that this was the most efficient treatment for post-traumatic stress. Search me, I don't know.
Okay, can you take several minutes to explain the structure of the frequency tables you showed?
Yeah, sure. I assume you're talking about the spectral display.
If you would like to, yeah, I guess so.
Okay, the spectral display that I showed earlier, what you're looking at is very slow frequency over on the left. So that would be a half a cycle a second, 1 cycle a second, 2 cycles a second. That is the delta and theta ranges. And you can see that the general state in the brain is that the amplitude, strength of those brain waves are greater than at the faster frequencies, like up in beta.
Thank you, Dr. Swingle, and we are going to have to move on now.
Family trauma. Okay. Here we have a situation in which, again, we see the trauma marker. We see a very, very, very mild marker for an attention issue, but when we challenge the person, ask them to read, then the the ADD marker disappears. So ADD is not an issue here. We're also seeing a marker for predisposition to depression. So I want to know what the trauma marker is, and when we have a look at the trauma marker, it turns out that the family was in a high level of strife and impending divorce and so forth. So this is something that the brain told me. The brain told me that this individual, excuse me, was going through some sort of current event that was causing some sort of emotional strife. Treatment. The fundamental treatment that everybody uses for post-traumatic stress disorder is relaxation. Okay? And there's no question but what it does have a beneficial effect. And there are tons of studies showing this sort of thing. And this is 60-minute twice weekly for 8 weeks, mindfulness exercises and so forth. But the reason I'm looking at this is they were looking at serum cortisol, and what they found was that they got nice increases in the cortisol levels associated with this relaxation. Now, here again, I'm wondering about the diagnosis. See, these are active duty nurses who are in the emergency room, and they're saying that 80% of them had post-traumatic stress disorder symptoms. Okay. Now, here's where I think we should not be using this term post-traumatic stress disorder. Post-traumatic stress disorder, you would not have nurses on duty in an ER. It just wouldn't happen, because they would dissociate and they wouldn't even know where they are if we're really dealing with post-traumatic stress disorder. This is a situation in which their anxiety symptoms were more severe. I think that's a better way of wording it. However, the important thing is that there was a mean difference in cortisol levels, and translation, what we always tell clients who are in any of these very, very high-risk situations is take care of yourself. If you take care of yourself with relaxation procedures, whatever they are, make sure your sleep is okay and so forth, your cortisol levels are going to improve, and that's your defense. Trauma release. The fundamental issue associated with trauma is, first of all, feel it. Now, the problem we have with that is every cell in your body is telling you to try to not feel the emotional pain. So you do all kinds of things to distract yourself. Exactly the opposite of what you should be doing. Feel it. The second is share it. And share it with a spouse or a friend or your barber. Or if push comes to shove and you have to do it, come in and see us. But the point is that you feel it and you share it. Okay? The third is sleep on it. Now, this is the most critical aspect of trauma processing, is sleep. Now, if needed, then what we do is we do the neurological treatments in which we actually correct brainwave activity. Now, sleep on it. First thing we do is have a look at your sleep architecture. And what we do is you send you home with an EEG device that's measuring brain activity, brain waves, while you sleep. And what we do is we measure it over at least a 4-day period. So we're getting a very reliable measure of what your sleep looks over a number of nights. So it's not just if you had a bad night or a good night. We know what it looks like over that period of time. So it's much more accurate than the 4-hour snapshots that they tend to take in sleep labs. Okay, this is a printout of the sleep over the full 5 hours that this person was asleep. Now, this person would have serious problems with trauma processing, and the reason for this is REM. REM sleep is rapid eye movement sleep, and during REM, the body is taking care, the brain is taking care of itself. It's doing its own psychotherapy, so to speak, in which you're processing a lot of the emotional events that took place during the day. It's also the time when the brain's doing its filing. So the stuff that you learned during the day, the brain files away during REM sleep. One of the problems that we have with individuals with deficient REM is they have a lot of trouble retaining information. So college kids will come to us say, I study, the next morning it's not there. We have a look, they don't have any REM. Of course it's not there. So the only two critical elements that I'm always looking at is deep wave sleep. You need about an hour, so this person's okay there. But you need about 2 hours of REM, and he's only got 19 minutes. So I know he has problems associated with sleeping on his trauma, so to speak. Not going to be efficient. Here's another case. Here we have about 48 minutes of REM sleep. He's very deep wave deprived. He only has 19 minutes, so he's fatigued all the time. But he's not efficiently processing. So the green lines are the REM, and he should have about 2 hours. He's very deficient there. The black is the deep, and he's very deficient there. This is the second night, an hour of REM, half hour of deep. Third night, 26 minutes of REM, 18 minutes of deep. Okay, so we know that that's a reliable measure. That is a reliable indicator of his very poor sleep quality. Now, the treatment of trauma at our clinic, we use very aggressive treatment procedures here. What we're doing here is we are measuring brain activity. See, there's a lead coming from the lady's head. She has headsets on so we can present sounds whenever we want. She has goggles on here that have lights in them, LEDs in them. We can present those any way we want. She has electrical connections here, so we're stimulating acupuncture points. It's all conditional on the brain. So when the brain is doing what we want it to do, we may turn on lights to keep it there. If the brain's not doing what we want it to do, we may use a sound that will suppress a particular waveform. This person has control of the amplitude, so there's no startle response. We use stimulation of acupuncture points triggered by the brain. And in this case, we often work with heart 6 and 7 down in here. And here's the treatment of an individual in which we're trying to drive up alpha. And you can see we get a change in, we're trying to drive down beta is what we're trying to do here, in terms of increasing the slow frequency in the back of the brain. And what we have here is a change in that ratio of about 30%, so that we're making the person more quiet. The adjunctive therapies that we use experiential psychotherapy, hypnosis, stimulation procedures, which a lot of you know about EMDR and OEI, and then somato-emotional release, which is a procedure for releasing emotion that's actually encapsulated in the body in various areas. Somebody asked about drugs. This is the use of paroxetine, which is Prozac. Is it Prozac? Yeah, I think it's Prozac. In any event, it's an SSRI, antidepressant, and this is comparing EMDR with paroxetine, and as you can see, the results showed that the 90% of the EMDR group had treatment response versus 36% of the paroxetine. One of the things that we've discovered is that antidepressants are not a good way to treat post-traumatic stress disorder. Now, there are medications that we use during the treatment process. For example, beta blockers are very, very useful at certain stages of treatment. Now, beta blockers take the edge off, and they are useful at certain periods of time to help modulate the amount of emotional reaction a person is having when we're dealing with the processing. So what we do is we restore the alpha response so that the trauma is released. We help the person process it with things like EMDR or emotional release procedures. If necessary, we might recommend the use of a beta blocker, but never, never, never an antidepressant. This is a person with severe drug addiction, and here we were using the driving of the theta beta in the back of the brain to quiet, and as you can see, after a single session of EMDR, the individual's ratio in the back of the brain improved quite substantially. Now, the reason I'm showing this slide is that when we're working using brainwave biofeedback, we can get a change in brain activity, obviously. But also if you're using some other process like relaxation exercise, like EMDR, like hypnosis, you get a change in brain activity as well. So it's a bidirectional condition. This is a vet I treated when I was at Harvard Medical School. And he was hospitalized. He was remanded by the court. What happened is he went to a military rally associated with Vietnam War vets, and there was a heckler. And this guy got very upset and went and got a gun. What he was doing with a gun is beyond me, but anyway, he had a gun and he unloaded it and went back to the event, the rally, walked over to the guy, put the gun to his head and pulled the trigger. Now, the police obviously were not at all happy about this, so they remanded him to involuntary commitment at the hospital for treatment. And what he had is a very, very major blunting of alpha at several locations, so he had a huge trauma marker. And in the back of the brain, now remember the back of the brain, what we want to do is we want to see that theta beta ratio sitting around 2 and sitting at about 0.5. So he had absolutely no stress tolerance. You know, it took about 3 sessions to restore the alpha response and get the emotionality under control. Here's what happens during an actual session. We're moving alpha, and you can see alpha is climbing, and once it releases, then what you're going to get is a big drop in theta, which is the processing of the trauma. Here's your beta, and then it restores again. So this individual had an emotional release while we're actually doing brain activity. So it's the most efficient psychotherapy on the planet because we engage the body's own mechanism for dealing with it. I talked earlier, often post-traumatic stress disorders are associated with brain injury because a person's been in an automobile accident or in a combat situation. We want to look at the symptoms associated with that because we may want to be treating this, which is the pattern associated with traumatic brain injury. And what we have here is whenever the brain is active, it activates the entire brain. That's why traumatic brain injury is highly related to seizure activity because there's a spreading phenomenon. So often if it looks like we're dealing with traumatic brain injury in addition to post-traumatic stress disorder, we want to do a full brain map to make sure that what we're dealing with is not the legacy of the traumatic brain injury as opposed to traumatic stress disorder. Fibromyalgia, very common symptom associated with exposure to traumatic stress.
Thank you, Dr. Swingle. And before I wrap it up here, I received a few more questions from the listeners. I just wanted to let you know we won't have a chance to answer them because we are running out of time, but you can email them to me at rita@swingleclinic.com and I'll respond with the answer. Okay, this is the book that includes all you need to know about neurotherapy. The title is Biofeedback for the Brain. It is written by Dr. Swingle and published by Rutgers University Press. It is available online at soundhealthproducts.com. Basic Neurotherapy is a guide for clinicians. It leads them through the procedures for evaluating and treating patients with wide range of disorders. It is also available at soundhealthproducts.com. Dr. Swingle offers education for professionals through Biofeedback Foundation of Europe. The professionals can register for online courses, webinars, and grant rounds. The schedule can be viewed at BFE's website at www.bfe.org. And Swingle Clinic also provides many educational activities. These include public lectures and webcasts for general public, grant rounds, sessions, workshops, consulting services, and one-on-one trainings for professionals. Our next workshop is scheduled for May 2014, and that will be the Fundamental Neurotherapy Workshop, and the Advanced Neurotherapy Workshop will run in October 2014. You can see both events listed on our events page at swingleclinic.com. And these are some of our upcoming topics for the future webcast. We will be talking about depression, anxiety, addictions, fibromyalgia, dementia, and more. We have all the webcasts scheduled on our events page at swingleclinic.com up to June 2014. If you are interested in registering for any of these future topics, you can do so right at our events page. And Sound Health Products is a division of Swingle Clinic. It is the leader in research and development of products for neurotherapy and biofeedback. Many of the products, such as sound healing CDs and MP3s, are used at home as aids to enhance relaxation, sleep, and attention. Most of these products have been developed by Dr. Swingle through many years of his research and experience. You can visit Sound Health Products at www.soundhealthproducts.com. And this concludes our webcast for today. We hope you enjoyed it. Our next webcast is scheduled for December 17th, and that is actually Tuesday. Normally we run our webcast on Saturdays, but there will be an exception next time, so it will be Tuesday at 7 p.m. Dr. Mari Swingle, who will be with us at that time, will be discussing the influence of media and technology on mental health. Have a great weekend, everyone. Bye-bye.